Hello, dear colleagues. Welcome everybody who is joining the webinar where we're going to discuss a really interesting story, one abutment, one time, truth or myth. So first of all, let me introduce myself. My name is Professor Tomas Linkevičius. I'm coming from Vilnius, Lithuania. And of course, we're going to talk about one abutment, one time story in terms of bone stability, because actually this is what we really want for our patients, and to have the case like here you see on X-ray when the bone is stable, and I'm sure that this restoration would last for a long time. So I'm coming from Vilnius. I'm working as a professor, Institute of Odontology in Vilnius University. Also as a private clinical practice, but as well I'm a director of private research center called Vilnius Research Group, and it's a really unique thing we have, because all the research which we do and also what you're gonna see today is made in private practice. So it's really, how to say, our input into the science of implant dentistry. And maybe some of you know me or have read about zero bone loss concepts. So it's concepts created how to develop and to maintain crestal bone stability. And actually, one abutment, one time has become a part of it. So of course today I'm not gonna cover all of the factors. We must will focus on factors which are used in one abutment, one time approach, and how does this really work in our clinical cases. Because at the end of the day, again, I will repeat myself, you see here clearly two nice X-rays with implants, with the implant level and abutment level. Both of them look nice. However, I'm sure that we want to have our bone as stable as possible. Like here, you can see just a series of X-rays from our clinical study which we're running, implant placement, provisional restoration, and the final restoration. And you see that the bone has really stayed just where it was during the implant placement. So we're going to talk about how to achieve this result and what features are really needed to have it. Of course, I must mention that recently Quintessence published my book, Zero Bone Loss Concepts, and also one abutment, one time story is also part of this book. And those who would need to repeat this, surely there is also interesting things in that book. As well, what how to say, maybe different thing from other courses and webinars is that all what I am going to talk about will be based on clinical publications. So we have now all about 33 publications supporting zero bone loss concepts, and part of them are really talking about this concept. But before we really go into details in one abutment, one time, let's talk a little bit. Let's start from the history, and let's start from the past to see that crestal bone loss was like with us forever. As I say, that when we talk about it in every, let's say, conference, in every meeting of doctors, actually two things are always covered: aesthetics and bone loss. So when you see at this nice X-ray from 1977, and when you see at this X-ray which was taken just this year, you can see that almost 42 years have passed, and we're still at the same, we still face the same problem. We face bone loss, and all the methods and all the strategies are really created to solve this problem. Bone loss has was so common that actually for many clinicians have accepted it as a norm. And this all the success criteria established by Albrechtson in 1986 say that 1.5 millimeter of bone loss after 1 year is a norm, is a success. So I think that this is really outdated, and we should be doing much, much better, especially with the concepts we can have, and for sure we can do better. Now, I'm always struggling with this because a lot of clinicians say, okay, so you have this initial bone remodeling 1.5 millimeters of bone loss, so what? So usually bone stops and doesn't proceed further in resorption. Okay, that's part of true, because of course, not every implant which has bone loss will need to take it out. But anyway, be honest, which one of these two implants you would like to be yours? Because you can see that these are really the same implants. And of course, I'm sure that everybody would say that on the left side, you would want that it would be your implant, although the right one just has 1 millimeter, 1.5 millimeter of bone loss, but still we would prefer that. So this means that we could really we would choose better. When I talk about Albertson's success criteria, which says that bone loss is unavoidable, I mean, this is really outdated data, because here you can see with MIS with 3, and is in this clinical case, you see that we have bone remineralization or growing with time, because at the delivery and 3 years follow-up, you see the bone really growing over implant platform. So that's what zero bone loss concepts are about, and that's what we would like to have. But I'm gonna start with the cases which I call what we want to avoid, because I'm sure everybody of us has these clinical cases. Like here you can see ideal situation. You see how wide is the bone, you see sufficient amount of keratinized attached tissues, the implant with platform switching and conical connection is selected, it's placed, nice healing of the tissues, you see the development of biological width, and after surgery we have screw-retained restorations in order to avoid semen remnants. So everything's really going into the right direction and nice adaptation of the tissues. But the real story is seen when you see the x-rays, when you see that for some reason around the implants you have bone loss, and that bone loss is not, after 10 years follow-up, as you can see it here. It's actually just delivery x-ray, and further you see bone loss increasing. So what was the reason for this, and how maybe one abutment one time could prevent this? So there is another case, really similar. Just look at it, single tooth restoration, case situation before implant placement and after, and the restoration of the implant. You see not only tooth, but you see how the tissues really were improved by handling them. But what I would like to emphasize here is that we really used one abutment one time strategy here, and you can see connect abutment from IS connected to the implant, a impression with open tray transfer, a screw-retained zirconium-based restoration, and the beautiful adaptation of keratinized tissues. But the most important is X-rays. You can see that 3 X-rays just after the placement, 2 months of the healing, and after delivery of the restoration, we see that indeed excellent bone stability not only of the bone below the implant neck, but also all the bone which is above the implant neck actually has stayed. So that's, I think, could be like the answer, how do we use one abutment one time? And if you think that in all the cases you have bone stability around above the implant neck, you might be wrong, because here, look, this is another case, a different kind of system, different kind of approach, implant level restoration, and you can see that all the bone which is above the implant neck is resorbed, and also you have bone resorption below the implant neck. So indeed, it is really not that easy to develop that bone stability. So how to achieve this result? And the one question, and the other question is how to make it stable. I mean, that this would not be just, one case out of 10 giving you 10% of success, and you just put this case on the presentation and see, look, it works. How to have it constantly with all of your cases. So here we go to this idea of one abutment one time, and actually, this is we have different ways to call this approach. So first of all, you can have implant level restorations when the restoration is screwed directly to the implant, and also you can have abutment level restorations when the restoration is not directly retained on the implant, but it's retained on the connect abutment or immediate abutment, which is torqued to the implant at the time of the surgery, and then all the restorations and all the prosthetic manipulations are performed at the abutment level. So that's kind of, implant level, abutment level, or one abutment one time. It's really the same thing, having, how to say, the idea that you do not disconnect the abutment from the implant. And if we look at this historically, so this is actually the first paper which started all this one abutment one time story. It was published in 1997 by Abrahamson, and he talked about mucosal barrier following abutment disc or reconnection experimental study in dogs. And what they found, that if you disconnect healing abutment from the implant, you will have recession of the tissues and bone loss. So what they concluded, that disconnection of the abutment from healing abutment from the implant is harmful, and at any cost it should be avoided. Now, of course, as I always say during the lectures, that animal study is an animal study, and we cannot directly extrapolate data from an animal study and bring it to the clinical level and say, look, if in dog study we had the bone loss due to disconnections, this means that we should not do it clinically. That would be a wrong way. So what is the evidence in the clinical situation talking about abutment disconnections? And when we talk about clinical evidence, then it becomes a little bit tricky, because like with every single feature, every single factor, usually you have not one, not two, sometimes three different approaches, three different truths, if we can call it. So for example, this one study, a really randomized clinical trial, which compared implant restorations with disconnection of abutments and the others without disconnections, found no difference between both approaches. But when you look at how the study was done, we can see that all the implants were placed at the level of the bone. So apparently, if the implant is at the level of the bone, so maybe, this implant abutment disconnections do not matter that much. From the other hand, we have, again, very high-level study, a randomized control clinical trial, showing different kind of situation that indeed, if you have no disconnections, you have less bone loss compared to the control group where you had 4 disconnections. But again, when you see at this, for example, X-rays, you can see that in no disconnections group, implants were placed deeper compared to this control group, which had 4 disconnections. So as I said that, the study should be as clean as possible in order to give some obvious reason and some guidance for clinicians. So what factors are most important in one abutment, one time story that we would get the result as you see it here when the bone remains really stable through all the treatment, because it's, as we said in the clinical studies, there are different kind of results. There is no one result saying strictly that one abutment one time is good or one abutment one time is not that good. So, of course, different factors are important in maintaining crestal bone stability. From implant design factors, what is really needed in order that we would achieve one abutment one time, no bone loss, is that the implant would not have polished part if it's submerged subcrestally. So, for example, here is, of course, all truth. If tissue level implant is placed deep in the bone, like you see it here, all this polished part is buried in the bone, we are gonna lose bone, and sometimes that bone might not stop, and we can just extrapolate and explant the implant, and the beginning of bone loss was because polished part was present on the implant and the implant was placed too deep. Sometimes there is also a very small, thin 0.5 millimeters polished part on the implant, and I always was thinking, so how harmful that could be for the bone stability. And indeed, if it's bone level implant and if implant is placed subcrestally, you can see obvious difference that on the left side you see the implant with polished part, even 0.5 millimeters polished part, and you can see bone loss, while on the right side of the screen we see implant with 3 implant placed 1.5 millimeter below the bone level, and you see nicer modeling of the bone without any bone loss. So of course, if we are thinking about using one abutment one time strategy, first of all, our implants should be without polished parts. So that's number one, what we should really think about. Of course, next factor is stability of the connection, how this connect abutment is connected to the implant, and what is the stability of the restoration, which later is connected to the abutment level. So here again, nothing new, my friends, that the microgap or connection between implant and abutment, if it's too close to the bone and if the connection is not that stable, it is obvious that we are going to lose bone. So here, implants which we are talking about, which we are discussing, MIS implants, have conical connection falling into category from 8 to 20 degrees, it's 12 degrees. So it's been known that its conical connection is sufficiently stable and really can be placed at the different levels of the bone. So for example, here you can see these famous videos showing different stability of the connection, and imagine that implant without conical connection, just with internal connection, is placed deep in the bone, and all this movement is inside the bone. So of course we're going to lose bone here, and that's no question. So only implants with stable conical connection should be used. But of course, some of you would say, so, okay, it means that we just need, the implant is with the most stable conical connection, like you'd see it here, and then we would not have bone loss. But that's not true, because you clearly see the sequence of different X-rays, implants with conical connection, with more stable conical connection, have huge bone loss even before the restoration, and you can see in the middle X-ray. And just after the restoration, you see massive bone loss around the implant with stable conical connection. So again, what is the problem here? And as I say, that we should never forget biology, because biology is very strong and usually wins over any implant design. So when we're discussing one abutment, one time story, we should always think in the context of biology. So what is the context of biology? What are the factors, biological factors, which are important for us? Of course, there are many of them, attached tissues, horizontal tissue thickness, biotype. But what we have not really been discussing for many years, it's vertical soft tissue thickness, which measured at the crest of the bone. And indeed, it's really similar to other biological factors like horizontal tissue thickness or even more attached tissues, because you see both of vertical tissue thickness and attached tissues have vertical component, but still they are different, because attached tissues are really measured more buccally and vertical soft tissue thickness is measured on the crest of the bone. And why it is important for us when we talk about one abutment, one time? Because from this vertical tissue thickness, we have the development of biological width, and biological width is actually our only protection from oral bacteria which come to our implants. Okay, so we continue. Yes, so we continue. And as you can see, the different cleanness of abutments is that when you see, again, this is the multi-unit abutment, similar to the one abutment, one time. And you can see that the part of the multi-unit abutment is clean. So it's a clean zone. It means that we had attachment or gluing adherence of the tissues to that abutment part. So that's why it is important to talk about vertical soft tissue thickness here. So we might have then two different scenarios, thin tissues and thick tissues. And maybe then one abutment, one time would differently, work in those two scenarios, because as I said, there is no, that one abutment, one time always works. We have different kind of data. So maybe the answer is here that in thin tissues it didn't work because the tissues were thin. So, and there is so many clinical and animal studies. One of them is just in front of you, the first study done by Berglund and Linde, really showing that if you have 2 millimeters or thinner vertical tissue thickness, the healing and formation of biological width would involve bone loss. And what we did already now 10 years ago, we published a clinical study. We really repeated the experiment which was done, the idea which was raised by the animal study. We repeated in clinical environment and arrived to the same conclusion that you must have sufficient thickness of the tissues in order to prevent bone loss. The same was done also with platform switching implants, that just using platform switching implants does not always solve this problem. So, of course, the question was then again, so what is this minimum amount of tissue thickness required to have bone stability? And here we had a really nice study performed with MIS with 3 implants, We placed them in 3 different soft tissue thickness group, ranging from 2 millimeters, 2.5, and over 3 millimeters. And the outcome was really interesting, showing that the thicker tissues got, the less bone loss was involved. And we found that actually 3 millimeters is the minimum tissue thickness, which gives you no bone loss in this kind of situations. So that's why we really have changed the threshold. We raised the threshold from 3 millimeters, from 2 millimeters to 3 millimeters. And of course, I think the optimum tissue thickness would be something between 3 and 4 millimeters. Now, of course, this is not at all a case when we have it in the patients, because we really seldom have patients having 3 or 4 millimeters of vertical tissue thickness. As a matter of fact, this is what usually our patients look like, about 2, 2.5, or even 1.5 millimeters of vertical tissue thickness. And one of the ways really how to improve this situation is suggested to place implants subcrestally. And when you place implants subcrestally, you have some changes of the bone above the implant neck, and you have the restoration. And from the other hand, if you have thin tissues and you would just place implant at the level of the bone, again, the biology will take its toll. You will have remodeling of the bone. However, during that process, you will have the exposure of the implant neck, and that would really be much worse than in other situation. So one of the ways was, which we tested also in clinical study, by placing implants subcrestally, again, in order to accommodate thin tissues. And what we have noticed, that we had a really nice remodeling of the bone, as you can see it here. This is with 3 implant restored with 3 millimeter height titanium base, and 1-2 year follow-up showing really stable bone without any problem. But of course, our main idea was that, well, when you place implant subcrestally, you always have this wall of bone above the implant neck. This is unique because if the implant is placed at the level of the bone, there is no, bone above the implant neck. Then you have tissues. So maybe there is a way to save this bone above the implant neck, because here you can see that implant is placed. Okay, so as I was saying, you see again the implant is placed below the bone level in order to accommodate thin tissues, but since it's an implant level restoration, including disconnections of the abutment, you see all the bone above the implant is gone, and you see even bone loss, even see more bone loss below the implant neck. So first of all, in order to continue and understand what's happening when we are restoring implants below the bone, we must, talk about 2 different issues, because bone remodeling and bone loss, in my opinion, are different. So we call bone remodeling is the resorption of the bone which is above the implant neck. So here on the X-ray, on the right side, you see the implant which has bone remodeling but has no bone loss, because there is no bone resorption below the implant neck. And if I would just show another example of this bone remodeling without bone loss, you can see it here, that implant is placed below the implant neck, below the bone, and you see resorption of the bone above the implant neck, but no bone loss below it. So bone remodeling is bone resorption above the implant neck, and here you can see that this implant also has no bone loss but also no bone remodeling, because only slight, how to say, amount of the bone above the implant neck was really touched. So again, different things. So how to achieve this? How can we save the bone which is above the implant neck when it's placed subcrestally? So here we made a really nice clinical study with MIS implants by using connect abutment, and I'm gonna show you primary results which are very interesting. Well, the idea again was that we place the implant below the bone, and then we attach connect abutment to the implant in order to move all the restorative manipulations away from the bone, that we would not disturb the bone which is there. So you can see again these two implants, they both don't have bone loss. However, the middle one has no bone remodeling, and the right one has bone remodeling. Now, there is obvious difference, and of course the clinical relevance of this, well, maybe we could discuss this, but I'm sure that everybody would agree, the more bone we have around our implant, the better. Another preclinical case where you can see that the connect level, placement of the implant and connect abutment at the provisional stage of the treatment, you see that again there is bone above the implant neck, while in the implant level treatment you can see that, of course, disconnections of abutment. So we had to disconnect them just here for 2 times in order to give provisional restoration, but still already that was sufficient to have this bone remodeling. Therefore, we designed a randomized clinical trial, and we wanted to test and to compare implant level versus abutment level philosophies and treatment modalities. Because, as I said, in different clinical studies, different approaches were used, and all those studies were not really as clean enough to give the clear outcome. So we wanted to test tie-base and also connect abutment, and we would see how that would work in ideally the same situations. First thing what we did, of course, we also used the same as similar parameters as possible, because for final restorations we used 3 millimeters height titanium base, gingival part, and also 3 millimeters height connect abutment, because they also have different heights. So you can see here in nice drawings that again how was the idea to move restoration manipulations away from implant level, that the implant level would not be disturbed anymore. So first of all, what was different from other studies, that we selected subcrestal position of the implants. And why? Because we used thin tissue biotype patients. So implants were placed below the bone in order to accommodate thin vertical tissues. How was that done? Because in order to make a study, you need to be really precise. That how did we measure that 1.5 millimeter deeper than below the crestal level? So indeed it was really easy. For example, we drilled, if we wanted to place 11.5 millimeter length implant, we would drill as if implant would be 13 millimeters. So just like you drill with a longer drill, and then you just position shorter implant. That's why we were always able to get exact depth of the implant. Now let's look at the connect group, or how that was done in the patients. So after inclusion criteria, had that we had sufficient bone thickness, sufficient keratinized tissues. So you see the implant was placed sucrestally, and just after the placement, we unpacked connect abutment, and connect abutment was torqued to 30 newtons directly to the implant and was not removed anymore. But here is a very interesting trick. You can see that connect abutment was 3 millimeters height, and that was also done on purpose because we needed to really have the connection, because new connection between prostheses was already on this connect abutment. That's why it should have been about 1 millimeter above the implant, above the bone level, because again, this is the micro gap. Now our micro gap is not at the level of the bone, at the level of the implant, but our micro gap is at the level of abutment. But anyway, it must be in sufficient distance from the bone. So that's why the connect abutment was placed that the platform would be about 1 millimeter above the bone. And now the healing caps were connected and sutured. So that was the surgical part of the treatment. And after 4 months in the upper jaw, we already switched to the prosthetical phase of the treatment. Next step was making provisional restorations, because we also wanted to see how we can condition the tissues around connect abutments. So again, impression was taken, and we fabricated the provisional restorations, which were screwed directly to the implants. And after 1 month, you can already see that the tissues got even more thicker. We see a nice contour of the tissues, and from this situation before, and you can see after, from this situation we took an impression to make a final zirconia ceramic crown on thigh base, which was then retained to the connect abutment. And this is, you see, the X-ray, the clinical picture of the finished restoration. And all 4 X-rays were taken after implant placement, 4 months after healing, provisional restoration, and the final restoration. And you can see that we have bone above the implant neck. The same was for the patients which were restored in the lower jaw, because we had upper jaw and lower jaw patients. But again, you can see this bone above the implant neck stays right when the connect abutment was used. And we can really explain this, in my opinion, that since the connect abutment is not disconnected from the implant, and also it is torqued to 30 newtons, because the connection has more sealed the implant compared to the healing abutment. That's, how to say, the prerequisite of success if we're talking about sucrestally placed implants. Now let's look how titanium base or implant level treatment cases were done. So again, it was really as similar as possible. Single tooth defects, lower or upper jaw, sufficient amount of bone and keratinized tissues, placement of implant below the bone, and instead of connect abutment, here we torqued regular healing abutment, torqued it with fingers as that is usually done during the work, and then in phase of the treatment we used 3 millimeters height provisional restoration, and also 3 millimeters gingival height final thigh base, in order really to be as precise as possible, because remember, in the connect group our connect abutments were 3 millimeters height. And again, you can see that already at the level of provisional restoration we had bone remodeling above the implant neck. That was obvious difference. So this is the delivery X-rays of both groups, both implants placed below the bone, and you can see here initial situations, both lower jaw, only implant level restorations, healing abutment and torquing it with hands, while in connect or abutment level restorations, connect abutment torque to 30 newtons and no disconnections of the abutment, which really then allowed the bone to be stable. Now, of course, seeing X-rays is one thing. Now let's calculate. So, because as I always say that in science, feelings are not welcome. I mean, we need to have numbers. So what were the numbers in this study? So first of all, let's look at the bone loss. So as I said, bone loss is bone changes or bone resorption below the implant neck. And we calculated that in connect abutment we had only 0.13 millimeters of bone loss. So only in few cases you had just for some reason a little bit, let's say, remodeling below the implant neck. And please remember, this is just delivery X-rays. It means that we just didn't see all those patients after 1 year follow-up. And usually after 1 year follow-up, this situation is even better. So I predict that we should probably have no bone loss in connect group at all. While in the implant level group or group restored with thigh base, we had about 0.6 millimeters of bone loss. So in some cases, we had bone resorption below the implant neck, and difference was statistically significant. From per implant soft tissue point of view, there was no difference. Probing depths were really the same around both groups. And what about bone remodeling or bone changes above the implant neck? Because again, you can see there are differences over here. So bone remodeling or bone resorption above the implant neck, and here we had even more differences than in the previous measurements. So in connect group, we had only 0.5 millimeters of bone remodeling. So as you can see it on X-ray, on the left X-ray, so just about 0.5 millimeters of the bone was really in some way affected by remodeling above the implant neck. While in implant level restorations, all the bone, 1.6 millimeters, 1.5 millimeters above the implant neck was gone, because that was sacrificed for bone remodeling. How to say, that was sacrificed to increase vertical soft tissue thickness, and that difference was statistically significant. So again, to emphasize and to finalize the study, you see that now in order to really understand this, we need to have two parameters talking about process, that remodeling is bone changes above the implant neck, and bone loss is bone resorption below the implant neck. And with connect abutment, we can really have no bone loss and almost no bone remodeling at all. In some preclinical cases, we really had even nice situations when we were placing two implants side by side. So we had some patients who required two implants. Those were not used in the study because we had to have one patient per one implant per one patient, but still it was really obvious and really a comparable situation. And you can see that how perfect tissues really were on both approaches of the implant treatment, connect and bone level. But of course, as you can see again on the X-rays, both implants look very nice. However, when you look at the more mesial implant, first premolar, you have more bone above the implant neck compared to the second premolar, which is bone level restoration, implant level restoration, while the first premolar is abutment level restoration. Now you might think that, okay, this is happening with all, let's say, all the restorations, all the one abutment, one time cases. So not always like this. We also have done study with Nobel on one cases, and if I would compare those just after delivery, so you can see that in terms of bone loss, you had 1.1 millimeter below the of bone loss around the one implant, and just 0.13 millimeters of bone loss below the other implant. And maybe the reason for this, as you can see nicely here, both implants placed below the bone, again in order to accommodate tissue thickness. However, in one case you have bone remodeling and bone loss, while in the Connect case you have almost no bone remodeling and just no bone loss at all. The differences, I think, is important that the shape and the height of this intermediate abutment. So the shape probably should be more, how to say, more narrow compared to the more protruding. So that's really important when you compare to different shapes of this multi-unit abutment. So I would say that, you know, we should stay probably more to the left side compared to the right one. And in order to really finish up, because we still have some few minutes for the questions, free take-home messages. So first of all, start that vertical tissue thickness should be measured before implant placement. So we should have what kind of thickness of the tissues you have. And then if you have thin tissues, then you can place implants sucrestally up to 2 millimeters. And then it's really a good idea to restore it with connect abutment in order to really to preserve the bone above the implant neck, which is above. So there you can say definitely that for sucrestally placed implants, one abutment one time significantly reduces bone loss, and this is really significant. Now, of course, then you choose as a clinician which is your favorite method of restoration, because you can choose also implant level restorations, but then you must be aware that all the bone above the implant neck probably will be resorbed, remodeled, because you are disconnecting the healing abutment. I also everybody invite to visit my site tomaslinkevičius.com, where you can really learn more about zero bone loss concepts. And for those from US, if they are watching, we still, I think, have few places in our 3 days hands-on course starting from November 1st, which I'm doing with Dr. Kyle Stanley. And here, of course, we are going to use connect abutment philosophy, how to really maintain crestal bone stability around implants. And with this, I want to thank you for your kind attention. Okay, so here we have 1, 2, 3, 4, 5, 6 questions, and there's another one. Okay, so there is a question, do you use anodized abutments on regular? All of these MIS look like anodized. On the regular, because you know, this anodized abutment is not a regular abutment because it's connected to the implant and is not removed. So generally, I don't use, for implant restorations, I don't use abutments at all. I'm using tie bases to do retained restorations. So how does this anodization reacts to the bone? Well, I don't know. I'm more thinking that in this cases you saw that the good outcome of the bone was dependent on two things. One, the precise connection of connect abutment, because it's really precise, and torque can get to 30 newtons because then it was really stable, and of course no disconnections because that did not really bother the bone. Well, the next question is connect abutment polished? If so, aren't you introducing smooth surface below the bone crest? That's a really good question. So connect abutment is not polished, it's machined. It's not, if we compare to tissue level implant, it's really smooth. So connect abutment is not that smooth, it has some roughness. And indeed, I also think that the shape of connect abutment is more friendly to the bone if we compare it to tissue level, because it really has a narrow shape. Can you remove connect abutment easily if surgeon placed long connect abutment? Well, I did not really try to do that. So in terms that you torque it to 30 newtons, then generally thinking you could able to untorque it and remove it. Now, would be there some, how to say, protection or difficulties in removing due to adhesion of the soft tissues? Well, it might be. Maybe would be interesting really to try it. So I did not do it, but maybe we would test it. Next question is, what is the difference between the connector and tissue level implant? Well, that's a good question, because from that point of view, they have some similarities, yet they are different. First of all, tissue level implant, this neck is more polished compared to the connect abutment. Then another difference is the shape, because tissue level implant has more, how to say, protruding shape, more aggressive shape. That's why when you place it subcrestally, you are losing bone as well. And also what I like about, well, what probably do not like about tissue level implants is that they have two micro gaps and they have more difficult to restore. And I cannot change any position. Let's say in some complication, because we all not immune to that. If you have some recession of the tissues, you can change, let's say, connect abutment to a lower one. For example, if I was using 3 millimeters connect abutment and I have a recession for some reason, okay, I can change to 2 millimeters or even 1 millimeter connect abutment, and you cannot do that with tissue level implant. So that would be my point of view difference between these two approaches. Okay, another question. Did you compare different positions of subcrestal implants, 1 to 3 millimeters? Are there any difference when using connect abutments? Well, our study did not compare that. Our study compared just single position of the implant, 1.5 millimeter below the bone, up to 2 millimeters, because sometimes, in some cases, it's difficult really to place them. But usually this was 1.5 millimeters, and in my opinion is that in general, one abutment one time is more useful for subcrestally placed implants. If the implant is placed at the level of the bone and if the tissues are thick, then one abutment one time in general approach is not that useful for the bone stability, and there are studies who have shown it. But my study showed that you have better bone stability of subcrestal implants. And by the way, please remember that this is just a delivery X-ray evaluation, because there was difference already at the delivery stage. So I'm assuming that after 1 year follow-up, we will have even more nice situation, because in my experience, After 1 year, when everything is not disturbed, when you don't touch components and do not remove them, bone really gets mineralized, remineralized even more. Some implant systems are one-piece implant and connect abutment. What are advantages compared to connect abutments? One-piece implants I consider very bad implant. I do not use them, and I would not suggest to use to you for just one reason. From implant design point of view, yeah, you don't have a micro gap at all, but then how do you restore it? You have huge undercut, and you cannot really remove semen remnants. So because when I talk about zero bone loss concepts, I talk also about prosthetics. So you cannot just look from surgical point of view. You must look how the implant would be restored. So one-piece implant, in my opinion, is very bad solution for the patients. Okay, so we still have 4 questions left. Also, when will you reveal some new results on immediate implants in consideration with zero bone loss? So we have, how I will tell you, we have 3 studies going on, 2 studies in anterior zone and 1 study in posterior zone. So we are waiting until all implants would be restored, and 1 year follow-up will go. So I think like probably next year we'll have some new data published. Which is the difference between connect and multi-unit abutment? So actually it is, in terms of philosophy, it's no difference, but connect abutment, what's the, how to say, the unique thing is that you can safely use it for single restorations, because usually multi-unit abutments are used for full arch restorations, and you torque prosthesis to multi-unit abutments with small screws up to 50 newtons, which is not sufficient in my opinion. But if you then have a cross arch splinting, then it's fine. So with connect abutment, the crown is torqued up to 30 newtons to this abutment. So that's why you have like a normal implant level retention. That's why you can use it for single restorations. And you saw in my study, all the restorations were really one single implants. Thomas, what do you think about Straumann soft tissue level implants? So about any implant, I would say that if it's used in a way it was designed, they are fine. So what I see usually with Straumann soft tissue level implants, they are placed too deep in order to have this remodeling of the bone. So in some cases it's successful, it stops, and in some cases it doesn't. And one of the cases I showed you in the beginning, that you have bone loss proceeding. Also, I think this is really important when the shorter implant is used, 6 millimeters, 8 millimeters, because then each millimeter of the bone surface is very important. Can we use connect abutment with E-base abutment of MIS? I think yes. I'm not really sure. I think you should probably ask the local distributor. I'm not really, I cannot answer this question. And last question is, I have seen implant systems where connector is integrated with the implant. Normal screw retained restorations afterwards. So if you're able to restore screw retained restoration afterwards, after implant placement, then it's fine. In my opinion, then it's really fine to do it. Okay, since there are no questions, thank you for your attention, and see you somewhere in the seminars or the lectures. Bye-bye.